We're going to talk broadly about catheter-based embolectomy for pulmonary embolism here. We've heard about catheter-directed lysis for approaching these patients from Greg, and we have heard about surgical embolectomy from Dr. Reddy. And it's important to remember that when you're talking about any catheter-based intervention for pulmonary, for the acute pulmonary embolism, whether it's catheter-directed lysis or a catheter-based embolectomy approach, there's certain risks and benefits that we're weighing against one another. Specifically, what are we hoping to achieve? Well, we're hoping that in the sickest patients especially that we can prevent early mortality. And we also are hoping in those patients and also possibly some patients who are a little less sick but very symptomatic that we can improve their symptoms more rapidly. And finally, and what's still an open question is it possible that we might decrease the incidence of chronic thromboembolic pulmonary hypertension down the line, which is about a 3 to 5% chance of happening for a new incident PE? And is it also possible that we would decrease the incidence of what is being recognized what's called a post-PE syndrome of folks who have functional decrements 6 months to 2 years later after their PE? Is it possible we may be able to change that incidence with early acute intervention? That's a big question mark. And what are we trading that against? A lot of procedural issues, and specifically major bleeding, intracranial hemorrhage, and the major bleeding can be associated with their catheter-based embolectomy devices or your lytic devices, obviously, with the use of thrombolysis. Intracranial hemorrhage, which seems to be much more of an issue with thrombolytic-based therapies. And then the chances of precipitating decompensation. You've got a patient in there who might look relatively sick to you, but is hanging in there hemodynamically, is not what we'd call a massive or high-risk PE, but you go ahead up there with a large bore embolectomy device, and next thing you know, you've turned an intermediate risk PE into a high-risk PE because you've moved clot around, and now their RV is now facing a very different afterload than it had just gotten used to. Or alternatively, you've caused respiratory decompensation or pulmonary injury, which can lead to pulmonary decompensation. So these are big issues during procedures that we have to consider. With that in mind, it's important to recognize what we know about the intermediate risk PE. We just heard a lot about massive and high risk PE from Dr. Reddy. These are the sickest patients who are on pressors, peri-arrest, or in the worst case have already suffered arrest. We're going to have to do something with these patients, and that's what these PERT teams are about. Maybe giving lytic therapies via catheter systemically, maybe calling our surgical colleagues for mechanical circulatory support or for embolectomy, or potentially using these devices in concert with some of those therapies. However, in the intermediate risk PE group, things are a little murkier, and they're murkier for a reason. So this is a big figure, but I want to point out one thing here. This is a meta-analysis from our group, and we look specifically at 1,750 patients who are randomized to systemic lytics versus anticoagulation over 17 randomized trials over 40 years for pulmonary embolism. And the surprising thing you'll see here that is probably not well recognized, I just want to draw your attention to the anticoagulant group. So this is 889 patients over 40 years with intermediate risk PE, so they have some RV dysfunction, but they're hemodynamically stable. And they're treated and they're randomized to lytics versus anticoagulants. And look at the mortality right there, short-term mortality. It's about a 7 to 30-day mortality. It's 3%. So it's not zero. These patients are dying in some incidents, but it's not, in randomized trials at least, 10, 15%. So it makes this window of what you have to affect mortality on relatively narrow. Can you affect mortality with these therapies? Perhaps. With lytics, there was a slight benefit to mortality, but it's only about a 1% change in randomized trials. But we need to be thinking, what else might we be affecting, and is it worth the risks of bleeding and hemodynamic decompensation to really be trying to affect making people feel better sooner, and what's a little bit of an open question down the line for chronic thromboembolic pulmonary hypertension and post-PE syndrome. So these are complicated questions. And it brings us to how the PERTs have chimed in on this. We've heard a little bit about that throughout this. So there have been the first three single center reports of PERTs were from MGH, Dr. Rosenfield here from Cornell and Cleveland Clinic respectively. And what I want to call your attention to is the intermediate risk groups. What did we learn from these intermediate risk groups? And this is everybody's first 2 to 3 years of experience, seeing 80 to 150 patients. Look at the rates of patients who had that were treated with what I'd call aggressive therapy, all the way from thrombolysis up to surgical or mechanical embolectomy. It was 19 to 35% of patients with intermediate risk PE. It wasn't an algorithmic approach where everybody who's got RV dysfunction and some positive biomarker did not pass go from their ED, ends up in a cath lab, and starts having stuff done to them. I bring that up specifically because I know there are some PERTs around the country that are unfortunately developing like that. I don't know if you can call them PERTs, but they're algorithms of care that are just not evaluating the patients clinically like these PERTs at Mass General, Cornell, and Cleveland Clinic have done, and try to slice off the top fifth to third of patients who they found to be sickest after evaluating them, after they carefully balanced that information that I discussed earlier in their heads. It's interesting that they all fell in this tight range at these expert centers too. Makes you think maybe what your range should be if you go out to think about treating intermediate risk P. Certainly I have this in mind. I'm looking at the top quarter of patients in my practice. But you see that the grand majority of these patients, then a third to 80%, were treated with anticoagulation in the intermediate risk group. So it brings us up to what do we do for embolectomy for these patients? Well, there are several embolectomy devices that exist. So initially the thought is if a patient has high bleeding risk, maybe you'll consider a catheter-based embolectomy approach for them. Or if they have contraindications to surgery, maybe an embolectomy approach is right even in the higher risk patients. 3 devices that exist are the NGO Vac, which is a large bore veno-veno bypass system. And that enables a suction thrombectomy of clot from the right heart and potentially also the pulmonary arteries, and it filters it through a little filter as it pulls blood from one vein and returns it to another. Next is a FlowTriever, which is really just a 20 French aspiration catheter, which is going in and sucking really hard. You do have the opportunity to adjunctively use the self-expanding disc to engage clot and pull it out with it. Rapidly around the country, this is being used more and more as a simple aspiration catheter. I've had it on the shelf for a few months, and almost every case I've used has been that way. And lastly, you have small bore embolectomy devices embodied by the Penumbra Indigo aspiration system. So this is an 8 French device, which also is an aspiration system to go and pluck away at clot and try to get it out in a way that's maybe less overall traumatic than these large bore systems, as a theoretical benefit here. But you're going to have to get ready for these PE devices to get out and be marketed with relatively limited data. And you can see that here, that the NGO Vac, the largest study, is from Ken Rosensfield's group at MGH that I was involved with, and you can see it only had 14 patients. FlowTriever was cleared. Again, Ken was the senior investigator of this study with the 108 patient study that achieved FDA clearance for this device, but still we have some open questions on where we go with how to use these devices in what situations. And the Indico system, you'll meet Aki Sista, who's running this study, similarly for 510K clearance with roughly the same amount of patients. So I find personally that the NGO Vac is a great device for clot in transit, which has been mentioned before. And so this is a case where a patient had intermediate risk P but has this big thing bouncing around in their RA. We can do these cases with moderate sedation. This is somebody with a transthoracic echo on the patient as we're fluoroing there under transthoracic. And all you're going to see here is the clot disappearing. And the clot disappears because it got sucked in to the NGO Vac. And this ends up being a beautiful way of getting rid of that clot without an open heart surgery, and it takes 5 minutes. It's unbelievable how well this works for RA clot, which is a niche indication. Sorry. This is that filtered clot that makes everybody feel good. The FlowTriever, you can see you're putting a large bore device in and you're trying to clear out. This is the lower lobe on the right is totally clotted off, and after FlowTriever, you're bringing back some of that. It's been seen in the FLAIR study that patients who had pre-existing pulmonary hypertension seem to have rapid improvements in mean PA pressure with the FlowTriever, but those who came in looking healthier maybe didn't achieve as much acute benefit. That's kind of logical and rational. Indigo small bore embolectomy, the jury, we still are waiting for results of the first study. So when you're weighing lytics versus embolectomy, catheter-based versus embolectomy, you're really trading off risk profiles. With lytics, you have increased major bleeding risk, increased intracranial hemorrhage risk. The embolectomy, you have what has not been totally characterized, but certainly what looks like a little bit of an incidence of PA injury and precipitating decompensation. This is a decision you have to make in the individual patients, is which of these risks are you trying to trade off against each other when you're trying to make that decision. And the current questions that I wrestle with every day are just 3 that I'll finish up with, and the patients I see all the time when I'm deciding whether to use embolectomy or not. First, we don't have a comparative safety or efficacy study of embolectomy against catheter-based lytics for intermediate risk patients. Second is, what is my risk of hemodynamic or pulmonary compromise with large bore embolectomy in a sicker PE patient? So it doesn't necessarily have to be a hypotensive one, but even one who has a heart rate of 120, is a little hypoxic. And should I only be considering that in patients who I have the opportunity for mechanical circulatory support as backup? And some of these folks are going to be thought to not be candidates for that, so should I even go up there with the device in those cases? I don't know the answer to that. And then lastly, what's the trade-off of small bore versus large bore embolectomy? Large bore seems more attractive for more rapid debulking, but does it have the chance of precipitating more decompensation? Theoretically, you might think so, but we haven't spelled that out yet. So with that, I'll just tell you the future of embolectomy devices where we have, it's going to be a little bit of the Wild West. You're going to see a lot more of these devices come out. I just showed you 3. And how we wrestle with these issues is going to be difficult. Hope is hopefully on the horizon as the FDA is engaging with National Registry from the PERT Consortium that Rob Lookstein's running to try to think through how to get evidence for these devices over the next 5 years. Thank you so much.